Good afternoon again, everyone, and just confirming that this is the Victorian Stroke Clinical Network's stroke webinar. Today we're broadcasting live from the new Redback conferencing studios in Melbourne, and we're very pleased to have our presenter, Professor Geoffrey Cloud, available to talk to us about the London HyperAcute stroke units. Just a few reminders. If you have any technical difficulties, please dial the number in your chat box and Redback will provide you with assistance directly. You can also make notes in the chat box and we can respond to you about technical requirements. For today's talk, Professor Cloud has asked that we keep questions till the end. So please do enter your questions in the chat box as you think of them. And at the end of the talk, Geoffrey and I will moderate those questions. And if there are questions that come through in themes, we'll answer them in groups. So please do type the questions during the talk and we'll answer them all at the end. And just finally, I'd like to remind you to please respond to the exit survey at the end of the talk. This helps us enormously in understanding who our audience is for these sessions and hopefully will assist us improving these sessions for you in the future. Now, I'd like to again hand over or welcome Professor Geoffrey Cloud and I'll let him introduce us to himself. Thanks, Geoffrey.
Thank you very much, Sonia. Good evening, everyone. Thank you for staying inside on such a pleasant evening. It's quite probably the most pleasant evening since I've arrived in Melbourne, which has only been for the last 3 months. So you'll see from the first slide, I've been asked to talk to you about the experience of the London HyperAcute stroke care model. These slides actually show my provenance as being St George's, which was the hospital I worked for the last 15 years before I moved to Melbourne. I'm now Director of Stroke at the Alfred. So it's both a pleasure and a privilege to present you on behalf of a huge collective effort that went into delivering and continues to deliver the London stroke strategy, and in a sense that is what I'm going to talk about today. And I would in particular like to acknowledge Professor Tony Rudd, who's the Clinical Director for Stroke in London, and several of the slides that I'm going to show today have been borrowed from him. So in terms of what I plan to take you through today, I will give you some background history to what was happening both politically and also at a hospital level with stroke care prior to the changes in London. Importantly, I'm going to try to explain to you what a HASU actually is, and even more importantly, why HASUs work, and introduce the concept of aggregation of marginal gains to you for those of you who may not be familiar with it. And ultimately, and most importantly, I'm going to share with you some of the outcomes from the changes in London and the HASU experience. So before I go on, I probably ought to, in the spirit of decorations, I ought to tell you that I am a full-time stroke physician. I'm very passionate about stroke, and that may well come across during the course of the conversation and presentation this evening. I have no apologies for that. I also potentially rather biased because between 2008 and 2015, I was the clinical lead for stroke in South West London. Remunerated for this for 4 hours a week, but as part of that, I was part of the Stroke Critical Advisory Group and the Stroke Clinical Leads Group for Healthcare for London, so I was very much involved in drawing up the strategy and the implementation of it. Also between 2009 and 2016, I was Associate Director for the Royal College Stroke Programme, responsible for the Stroke Sentinel National Audit Programme, which is similar to OSDAT and OSCARES in Australia. Again, I'll be mentioning this throughout the talk. So, a bit of background for you. In 2006, there was a National Audit Office report about stroke care. This was very seminal in what was due to happen because the National Audit Office report in the UK is answerable to Parliament. So Parliament has to act on recommendations, or respond at least. This has lobbied for several years previously, particularly by the All-Parliamentary Group on Stroke, as well as the Stroke Association, which is the equivalent of the Stroke Foundation in Australia. It was informed in part by the ongoing audit that had been present since 1998 on stroke care, which is called the Sentinel Stroke Audit. This had been a retrospective paper-based audit to start with, but a move to web-based design in the millennium, and really had given some grip and some handle on how disparate stroke care had become in the United Kingdom, and in particular some of the failings are around acute care, which if you look at the slide, you may be able to just work out that the title of the National Audit Office report was reducing brain damage, and it was really a focus on delivering stroke as a medical emergency. And this led to, in 2007, the National Stroke Strategy for stroke care within the National Health Service, for a blueprint or a framework for delivering stroke care for the very first time, and long overdue given the fact that it's the second commonest cause of death and leading cause of adult disability. So that was really the background to what was happening in London. I noticed that in 2007 something else was happening similarly in Victoria, and that was the stroke care strategy for Victoria, launched at exactly the same time as the National Stroke Strategy in England. But something else was happening in the country about this time. It was an exciting and anticipatory event, and that was we were planning for the 2012 Olympics, and that was really focusing minds particularly in London. It was important for there to be an Olympic legacy in the capital, as well as wider in the country, and health was to become part of this, and in particular major trauma services and acute stroke care. I may revisit the Olympic theme later on, but the other thing I want to share with you is this. Stroke had become political almost overnight. So this is the stroke unit at St George's at the beginning of 2008. I've been there since 2001. We had not seen a politician show any interest in stroke at all. On this particular day, the gentleman in the pink tie is the Secretary of State, who just had launched the National Stroke Strategy, Alan Johnson. And the chap just to his side, some of you may have seen from the media, that's Sadiq Khan. He's most known currently, internationally anyway, as being the successor to Boris. He's now the Mayor of London, but at the time he was the MP for Tooting, which is where St George's lies in terms of constituency. And there they were, the two of them, on our acute stroke unit, speaking to our patients in the ward. This had never happened before, but gave you a sense of the political interest in stroke care at the time. And so the London Stroke Strategy came to be conceived. The idea that it was an end-to-end look at the entire stroke care pathway had to start somewhere, and it started with acute care and implementation. But together with major trauma, went through the public consultation process and subsequently delivered both guidance on rehabilitation services and life after stroke services subsequently. So in order to give you an idea of why stroke was chosen as a good target for political driven change in London, this is a slide which shows each of the 32 acute hospitals within the London area that had an acute stroke unit. These are benchmark scores from the 2006 Sentinel audit, and what you'll see that there are some on the left-hand side that are performing extremely well. In fact, these are the best in the country at the time. On the right-hand side, you see people scoring probably half as well, and these are equivalent to the absolute worst in the country. So within one relatively small population in terms of the geographical space, you have some of the best and some of the very worst stroke care in the health service, and really a postcode lottery. Now, the other important thing to look on the second graph below it is what had been happening in terms of relative stroke improvement in each of the 32 hospitals. So the hospitals with the red bars above the line, they'd been making progress. Their scores had been getting better, but others had made very negligible change and some had been going in reverse. So what was absolutely clear in this is that we could not leave it to the hospitals themselves to improve their care. All we were going to get was more disparate care. The situation was ripe for change management, and the change really had to be top down, given the target of having equitable care for all Londoners. So you may recognise this as a schematic map of London. I'll just show you. This is the River Thames. So you've got central London in here, and north and south, west and east. And one thing that you'll notice in this demographic is that the darker purple is where patients with stroke were in the capital. If you compare this to the next slide, which tells you where the hospitals are, you can see that there's a clear mismatch. For those of the medics on board who are used to looking at perfusion imaging, I think I can clearly convince you that there is an obvious mismatch. And what was more the issue is that around the centre was where the university teaching hospitals were. Some of these hospitals were only a mile or two apart, and in terms of high quality services, these were clustered in around the centre. So a big disparate mismatch between where the high quality services were and where the patients were, or the people were, that were suffering from stroke. So I'm just going to take you through a few slides in terms of how the process was managed, and it took around about 18 months to 2 years to get this right. The first and foremost thing was there's agreement from all the individual commissioners of stroke service in London. At the time there was 32 individual ones, so it's not like Victoria where there's just a state government. There's 32 individual what called primary care trusts, each of which look after a population of people somewhere between 250,000 to 500,000. And they formed a joint committee of primary care trusts to support the process, and importantly, were prepared to invest an additional £20 million in stroke care to make the step change. Now this seems rather a lot of money perhaps on face value, but let me equate that to it's probably equivalent of a cup of coffee in Starbucks, which as you know is rather ordinary, per Londoner. And it's not far off the equivalent cost of a gold medal in Rio 26 for Team GB either. So clearly an additional investment above and beyond what was already set aside for stroke care, and you'll see in subsequent slides how that was spent. A project board was drawn up with major stakeholders involving commissioners, managed clinical networks, managers within the health service, a strong viewpoint from patients and patient charities, voluntary groups, as well as clinicians. And the idea was that the stroke care pathway would be divided into the concept of hyperacute stroke care. Initially, there was some debate whether this was going to be the first 24 hours care, first 48 or beyond, but a hyperacute stroke session of care, then a rest of a period of time in a hospital stroke unit, and rehabilitation and community afterwards. TIA was also looked at the same time. And the idea was that there would be evidence-based standards which hospitals had to demonstrate their potential for achieving in the designation process, but also were then required to deliver against in order to achieve an enhanced tariff for stroke care. So in a way, this was performance-related pay. As I mentioned, there were several ranges of models that were considered, and with that also different numbers of HASUs in London, from anything from 4 to 14 were being proposed at the time. And this is with external consultation and with consultation within London itself. So agreement that additional funding would be paid as an enhanced tariff was key to, I think, the whole success of the project, and in particular agreement around how the acute care tariff was split. So there was a bed day tariff for the days spent in a HASU, and then the rest of the tariff was given in a spell, a bit like the WEAS in the acute hospital. So the next bit of the process was in terms of implementation, setting the different stages of achieving the standards. And it's important to say at this point that the stroke unit standards was set in the designation process and had to be achieved before the HASU centres went live. It's very clear that the stroke units had to be up to scratch for the HASUs to work, because you did not want to send people out of a HASU into poor care. That would defeat the whole object of the enhanced care in HASUs. And the basic premise was that all sites had to demonstrate that were designated that they could achieve at least the basic A standards, and then over an 18-month period they was rolled out that they would get up to the D standard. And these standards involved both infrastructure in terms of staffing levels, training, as well as process of care. So there was a bidding process, so there was all hospitals were invited to bid for HASU, stroke units and TIA care, and these were reviewed externally, and I think there were clinical experts from Victoria who were involved in that process. And the final decision ended up being both on the quality of the applications, but most importantly, I think, based on the geography of where the units are. Remember what I was saying about the mismatch between all the hospitals being in the centre and the patients with stroke being on the perimeter, and that had a major effect in actually what happened with the designation. And as you can imagine, there were winners and losers in this process, and a lot of university teaching hospitals did not get their wish to be a HASU. So in the final model, we had 8 HASUs, each with their own associated stroke unit, or in an acute hospital, and that was a total of 124 HASU beds for London. The population of London is between 8 and 9 million. There was a further 16 stroke units, making it 24 in total, with coverage across London, which was divided broadly into 5 sections. There was a southeast and a southwest, a northwest, a central, and a northeast. And each of the stroke units had a 5-day-a-week TIA service, which was to roll out to 7 days a week with the implementation. A key issue with the model was repatriation, which was required after 72 hours for those people that weren't able to be discharged home directly. So around about 60% of stroke patients did need to go on to a local stroke unit. And there were financial incentives for the HASUs not to hang on to their acute stroke patients and the stroke units to repatriate them. Very much a carrot rather than a stick approach to the whole of this process. One of the challenges was this 400 nurses and around 100 therapists were required to make this all work. So this is the final model. You'll see there's an inner ring. This is where I was working, St George's in the southwest. There was King's College in the inner southeast, the Royal London in the east end of University College Hospital in the centre, and Charing Cross in the west. And then an investment, and a huge investment in more peripheral hospitals, particularly in the outer southeast, which had the highest prevalence of stroke. That's the Princess Royal University Hospital, which had been one of the struggling stroke centres prior to the redesign. Then Queen's out here in the east, and Northwick Park. One of the things that also informed the redesign was what had happened previously with the heart attack centres in London. So we had good ambulance information and intelligence about how quickly people could move from the outside and the periphery of London into the centre. So this green this green area shows you the 30-minute travel time into a heart attack centre, which was then mapped onto where the HASUs. And in fact, the median travel time, so that's the 50% of the time the travel time was less than this figure, was 18 minutes from anywhere inside London to a HASU, as it turned out. So this modelling turned out to be very accurate. And this is what it looked like in 2010. We went to implementation. You can see that London is represented by 24 centres there and 8 HASUs. This is South West London at St George's, and St George's Hospital is at the top here. That's the Atkinson Morley Centre, and we had 3 spoke hospitals: Kingston, St Helier and Mayday Hospital. The population is about 1.6 million. You can see the scale there with 5 kilometres in the bottom corner. And prior to this, we did have a 24/7 thrombolysis service for the whole of the patch, and it was delivered in a different way. Patients in the daytime went between 9 and 5 went to their local hospital, and out of hours they were conveyed to St George's. So there was a sort of hub and spoke already in place, but at that time we were thrombolysing no more than about 3 or 4% of patients within South West London. So this is my last slide on implementation. I think this is giving you some idea of how the governance worked, and there was a London Stroke and Cardiac Board which oversaw the implementation. The clinical networks were absolutely vital to the whole process, and I can't tell you how delighted I have to arrived in Victoria and find that there's already established stroke network, because this would not have happened without a managed clinical network. It was the clear bridge between the clinicians and the commissioners, and in a spirit of mediation and coercion, as I said, more carrot than stick, that we got things done, and that was mainly due to the role of the clinical networks as much as the collective willingness of the clinicians on the ground. And it was the networks that organised inspections with commissioners, and as a clinical lead I inspected other areas outside of my part of London on an annualised basis to see their progress against the implementation standards. And with a bit of peer review and encouragement, we saw a real transformation about how stroke care was being delivered. A lot of that was underpinned by education and training, and we fostered a number of events to do that, which I'll tell you about a bit more later. And there was a willingness to collect data, and this time we didn't have, in 2010, a prospective web-based continuous data tool for stroke, although that came in 2011, 2012, with a continuous audit, to try and get a sense of how people were managing, particularly managing things like bed capacity. And the whole thing was driven by a cohort of extremely good leaders. Not all of whom were doctors, many of whom were allied health professionals and nurses. It really was an Olympic effort. So I'm moving on now to the next bit of my talk, which is to try and tell you a little bit about what a HASU really is. So, based on the London experience, a HASU is a 24/7 specialist stroke centre. That means the care is the same on a Sunday as it is on a Wednesday. It's inclusive, does not take only patients who may be for reperfusion therapies or thrombolysis. It takes all suspected stroke patients for further investigation, diagnosis and management. In the London model, we looked after patients in HASU for up to 72 hours. A number of patients were discharged in 24 or 48 hours, but it was a 72-hour care model, and there was some uncertainty about this to start with. Similar models had been trialled in Toronto, and there was some prior experience, but not on the same scale of the redesign as in London. And I'm pleased to say that 72 hours seems to have worked very well for London. What's really key was there were clear protocols, particularly with the ambulance services and the ED departments that did not have HASUs. And this was vital to the whole success of the HASU model. So the scenario may be that a patient may live almost opposite a local hospital, but if it was not designated as a HASU, the ambulance would drive past that and take them directly with a pre-alert to the local HASU. And they got this right, surprisingly, really from the start, at a very high degree at times. The accuracy was over 90% within the first 6 months of getting the right patient to the right ED department. Key. And with that, the reception they got when they went to a HASU ED department was all important. So with a pre-alert, they were met by a dedicated stroke team. They didn't go through, they didn't queue up with a triage to see, to wait in line to see a junior ED doctor. They're met directly by a dedicated stroke team. And one of the key components is staffing and the level of training of the staffing. I'll say more about that in a moment. And in particular, the staffing levels. Now, in terms of the investment that went into this model of care, the number one expenditure was on people and predominantly on nursing staff. Let me explain why I think that's so important. So these are the staffing levels for London HASUs and stroke units. You'll see at the top that these are per 5 beds and these are per 10 beds, but the nurses hold this. WTE means whole time equivalent in UK speak. And essentially the numbers that we had here were equivalent to an HDU. So broadly speaking, you've got one nurse between two patients on a HASU. And this is work we've done from the Royal College audit, and I draw your attention to this because I think there's an extraordinary thing in Victoria as well in terms of the statewide nursing levels. I don't know anywhere else that has the same level of nursing staffing throughout its acute hospitals, but it's really important. So in this paper, which is an open access journal paper, so you can download it if you're interested, essentially the bottom line is the biggest determinant of mortality in stroke care in hospitals is the number of nurses on duty. We showed this very eloquently in this paper in a large cohort of several 100,000 people. So what this is saying is that the mortality goes up as the number of nurses per 10 beds go down. And anyone who works in stroke will probably appreciate that. I mean, in terms of the common causes of mortality, they're usually complications, and early recognition and prompt intervention are the key things that are going to change that. So within this, there was a huge workforce initiative. Some of the things that we did in London was an e-learning program that was developed by partners in Imperial College. We had a lot of success with simulation centre courses, particularly not just for thrombolysis, but for acute stroke scenarios. And these were between teams of doctors and nurses, predominantly doctors and nurses. We didn't develop courses particularly for allied health professionals, but they have been assessed. And again, there's a reference there. You can read more about how successful these have been in stroke, and I would commend them to you as a potential way forward for improving team working roles and responsibilities, and particularly developing really efficient hyperacute stroke care in the ED. We also run and ongoingly run conferences for paramedics around stroke recognition and feedback them around what happens with the strokes that they convey. And importantly, as well as employing extra staff, we were training them, and we developed new competencies for both nurses working on a HASU and an SU, and for allied health professional groups. An example of this is the London Stroke Nurse Competency Workbook, which again, you can download this from the internet to see how this tied in the individual nurses' personal development. It was work-based assessments, some lecturing and mentoring, and it was very successful, I think, in equipping nurses to do the job. I think the difference is here compared to some of the stroke services that I've seen in Australia, that these were geographically separate units, so they were full of stroke patients, so the nurses were not having to contend with other specialties that are only dealing with stroke, so it was appropriate they should be upskilled in stroke care. So I've mentioned about the staffing. The other issues were all the HASUs were equipped with continuous non-invasive physiological monitoring. This is important for two ways, as I'm sure you all know. One is in terms of looking for etiological causes of ischemic stroke, particularly atrial fibrillation, but also so many patients with stroke have communication difficulties and can't really express their symptoms or how they're feeling, and so non-invasive physiological monitoring is a good way of pre-warning or preempting such complications as stroke-associated pneumonia or sepsis syndromes. There's a rapid access to diagnostics, and this meant not just in the ED department where we were looking to try and scan patients within an hour of arrival, and certainly within 15 to 20 minutes when they're in a thrombolysis window, but also diagnostics to look for etiological causes of stroke. So having good 7-day access to MRI and vascular imaging, as well as cardiac imaging. So on our HASU, we had ward-based echocardiograph service every day in the afternoon, for example. So people weren't hanging around waiting for diagnostic tests in the HASU, and the tariff reflected that in the bed days tariff. And most importantly, there was this continuous audit of process of care and clinical outcomes, which again, I'll demonstrate in a moment. So why have HASUs worked as a concept? Well, if you're looking at clinical service improvement, you need to probably think about it in in this sort of arrowhead or pyramid, I mean, we're all judged essentially by outcomes, so mortality rates, length of stay, these sort of thrombolysis rates, these are obvious outcomes in stroke, but to try and understand them, you really need to understand the infrastructure, the staffing base, how far is the scanner from the ED department, how things work within the infrastructure of the hospital, as well as the process of care in terms of how patients flow through. And this has been, again, this is work we've done from the College Stroke Programme. This has been proven, really, that in this paper in the BMJ, we demonstrated that bundles of care and process of care was really key to determining 30-day stroke mortality. And this is, I think, I've been very interested since I've been here to get onto the tail end of the T3 trial, which many of you will have taken part of, which embraces this in terms of the bundle of care within the ED department transitioning to acute care. And these are the sort of things that make a difference. So it's significant. Click through that. So in terms of how the London reconfiguration was evaluated, process of care and outcome data was available from several sources. The ambulance service themselves were collecting data. We had SIGNAP was the pilot of SNAP. So this is, again, the continuous web-based audit, nationally based. SIGNAP stands for Stroke Improvement National Audit Programme. That looked at the first 72 hours of care, continuously web-based for the first time ever in stroke care in the UK. That started in 2011, went to 2013, and then was replaced by SNAP, which is a bit like the aspiration of OSDAT, collecting data throughout a patient journey from day 0 up to 6 months, in fact. I mean, one of the key things in terms of quality of stroke care that needs to be judged is the fact that patients are spending less and less time in hospital now. So what happens to them when they leave hospital has never been more important. There was a minimum data set for London, which was usurped by SIGNAP when it came on board, and as well as some Department of Health vital signs data, which were nationally collected and used as comparators. There was also an NIHR funded study from the service delivery section looking at how well the centralisation of stroke care in London had worked, as well as an NHS London Health and Economics study, and I'll mention both of these in a while. So, quick pause. I'm not sure if anyone who is still awake can tell me who this person is. Can anyone? I'll click the details and there'll be some sort of appropriate prize for you. So can someone type in the name of this person? Everybody knows who this smiling bald genius is. We've got any responders? Nobody knows who it is. Shall I have to tell you? So this fellow is Sir David Brailsford, who was in charge of Team GB cycling, and he came to prominence in the 2008 Beijing Olympics, which really started the cycling revolution off in the UK amongst middle-aged men, amongst others. And he was responsible for the Brits to be having an official complaint lodged by the French team in 2008 that the wheels were too round. The wheels were too round on the bicycles. And he has gone on to basically replicate the success in 2012 and most recently 2016 the Olympics, and also take over charge of a cycling team called Team Sky, sponsored by Rupert Murdoch. And they've won the Tour de France 3 times in the last 5 years and been incredibly successful. But his approach to cycling, I've met David Brailsford, he's a very interesting fellow, but his approach to cycling is all about this, and this is not a new concept in management, it's aggregation of marginal gains. So it's looking at anything which is modifiable, which can be adjusted to the benefit of the end game, you should look at, even if you're making 1 or 2% difference. If you add up the 1 or 2% differences, they add to a meaningful difference at the end. I think this is really the essence of looking at acute stroke care, the aggregation of marginal gains. So what makes the difference in acute stroke care then? Well, I think you can probably say thrombolysis does, and thrombolysis makes a difference in up to around about 15% of the population, maybe 20% in some populations, so a significant minority of patients their natural history of stroke can be changed by that. Certainly the most important thing in terms of the net value is access into stroke units. And this is really what has changed the face of stroke care in the NHS, is the growth and implementation of stroke unit care, which don't look like this anymore in the UK, I should add. And then more recently, we've got endovascular clot retrieval, which is a very powerful treatment. And currently, I think probably only 2 or 3% of patients are currently benefiting from this. But we hope that that would double, triple, maybe even quadruple over the next 3 to 5 years. But there's still challenges around implementing. So stroke units really are probably the key thing to all of this. But let's just go back and consider what the marginal gains are to be made, starting with thrombolysis. Now, thrombolysis, as you know, is essentially this. Notice you do have Mr. Muscle in Australia. It's used to unblock blockages in sinks and U-bends in the UK, and that's essentially what it does in stroke. It dissolves clots. And one of the key things about thrombolysis is that it needs to be given in a very timely way. So most of you will have seen this. This is the individual meta-analysis from the stroke trials looking at the odds of having a good outcome. This is a very good. This is essentially a cure from stroke with a ranking of 0, 1 over time. And the key issue that this decays with time. So the idea is the more people you can treat at this end of the curve, the less people you need to treat to have a really good outcome from stroke. So that's really, really important. So this is data which is now a little bit old, but looking at the first couple of years of what was happening in London compared to the rest of England. So this is post-go live for HASU, which happened in July 2010. So this is your odds ratio of, I'll come back to this in a moment, but arriving and being met by a stroke team in less than 15 minutes, being scanned within 60 minutes, and having a door-to-needle time at the time of less than 60 minutes. So all very significantly increased. The interesting thing in London was that the patients weren't coming into hospital within an hour that quickly. And I think that's an issue of the demographics, the multicultural nature of London, and the public health campaign that followed the National Stroke Strategy probably wasn't necessarily that relevant to Londoners in terms of the early recognition of stroke symptoms and making the correct call, which is to phone for an ambulance straight away. And this continues even now to be the case. So it's a little bit of a sting in the tail that patients aren't picking up the phone as quickly as they are in other parts of the country. But when they do, they're conveyed very quickly to a HASU, and there they get very good thrombolysis type care. I just want to spend a little bit more time on this. So this is work that we've published. Again, this is you can look at this journal. It's open access in stroke. And this is around the volume. This is the number of cases that have been done. These are all the hospitals in England, Wales and Northern Ireland. Each dot is a hospital. Looking at the number of cases that they treat against how their process of care differs. So on A, you've got median arrival to scan, that's door to scan time, and this I guess is this is where the real money is. This is door to needle time. So what I would propose, if you just look at this and you put a line at 100 thrombolysis cases a year, what you see, and let's just concentrate on the door to needle time for a moment, you can see that all the hospitals that are doing more than 100 cases a year have a door to needle time of less than 60 minutes. This is over several years worth of data. Now you can in lower volume centers, these ones are doing about 40, 50, you can clearly, it is possible to get good door to needle times, but the majority are way above that. So there is a effect of volume, and those of you working clinically in acute stroke service will recognize this. The more frequently you're going through stroke calls and running the thrombolysis pathway, the better at it you're going to be. There's clearly a volume effect. And what this all added up into London was a real transformation in the number of patients that are being thrombolyzed. And I told you at St George's that even though we had a regional hub and spoke 24/7 coverage of patients with thrombolysis, we weren't being inclusive. So the number of people that we were thrombolyzing was probably around about 5 or 6% before this. And this is for the whole of London. You can see a step change here. And I should tell you, for historical reasons, the denominator here is not ischemic stroke, it's all stroke. So it's underreporting that if you're going to look at that. So in London, approximately about 1 in 5 stroke ischemic stroke patients are getting to hospital in time to be thrombolyzed. Let's talk more about stroke units. So people talk about the black box of stroke unit care, unpacking it, and what really is important about stroke unit care is it's about coordinated multidisciplinary care with stroke-specific protocols, guidelines, care plans. Having a group of staff that are really interested in stroke helps, and who are knowledgeable and educated and have training in stroke. So these are all really important factors. Let's look at some of the other things. Again, going back to the sign-up data that I showed you before, looking at different bundles of care in terms of access into getting swallow assessments, which we now know is really associated with stroke-associated pneumonia, seeing a therapist, getting adequate hydration, being directly admitted into stroke unit. All of these bundles of care were far more prevalent in the London HASUs compared to the rest of the country. All of these are highly significant. This is data from a couple of years ago, but it's been the same since. We look at this nationally. I'm just going to give you a snapshot of what this looks like in UK terms. So one of the big differences between the UK and Australia is that we publicly report all our stroke performance data. So you can go on to the SNAP website and look at this. So these are the London hospitals, and this is the SNAP performance. I'll take you through it. It's a busy slide. So these are the hospitals here, the HASUs and the SUs. You've got, these are sort of the overall performances, but in terms of process of care, it's split into 10 domains, and you're ranked A to E. So this is London, and I just want to sort of, I've taken this snapshot to show you that London, this is just one quarter, we publish it every quarter. You can see it's predominantly a green blanket, whereas if you went to other parts of the country, you may, well, and I haven't been disingenuous and showed you other parts of the country, you'd see much more orange and red tartan. So this is how we look at it. Another way we report it, again, it's all public reporting, these sort of regional maps, and again, you can see this is national data looking at how the chances of getting a scan within 60 minutes of arrival. So London is pretty purple, but there are other areas in the country which are catching up. I think this is data from 2015. And we would regularly report on outcome data at a regional level, transparently in the public domain, publishing these sort of graphics which clearly show you the hospitals and how well they're doing in terms of whether an A, B, C, D, or E, and A is good and E is bad. So these are sort of things that were helping motivate and drive the process of service improvement. I very much firmly believe that service improvement is a bit like driving a car. You need something to keep your foot on the accelerator. As soon as your foot slips off, you start to stall and go backwards, and this sort of public reporting has certainly helped in that respect. So Dave Brailsford's sort of rhetoric about marginal gains, I think the issue with London is that we have made changes across the whole of the pathway. All the things that are modifiable seem to be slightly better in some way than what's happening outside, and the HASU effect has definitely been fundamental in that. Okay, so let's talk about some outcomes, and the one that you can't escape is mortality. What I'm going to show you and talk you through now is the STO-funded NIHR evaluation of centralisation of stroke services in London. And the reason why I'm showing you this, because I think it has got implications for redesigning stroke services within metropolitan areas. So in this analysis, there was a comparison between what was happening in London, and also at the same time, remember the National Stroke Strategy in 2007 was the whole of the UK. It wasn't just confined to London. We were doing our own sort of Olympic legacy bit, but other places were looking to improve their stroke care. And Manchester, smaller, but one of the biggest cities in London, also were looking to redesign. And they came up with this sort of model. So let me just explain to you what this is. So this is the schematic model of what was happening in, commonly prior to the redesign. So if you had a suspected stroke, you went to your local stroke hospital and then you were discharged from there. So in Manchester there were 12, and in London, by the time this went go live, 32 had become 30. So in this model, which is the Manchester model, they triaged patients who they thought may benefit from thrombolysis only. So people with onset within 4 hours. And they sent them to either a comprehensive stroke centre or a primary stroke centre, essentially a thrombolysis capable hub. But if you were outside of 4 hours, you just went to your local hospital. And the idea was that you would then be discharged from there. So you can perhaps see already the issue for this is that the triage happens pre-hospital. It puts a lot of onus on the paramedic team to get this right. Compare this with the London stroke model. So if you suspect a stroke model, you go straight to a HASU. There's no differentiation whether you're being considered for thrombolysis or not. Then if you're not discharged into community from the HASU, you go to your local stroke unit and you're discharged. So mortality data. The way this is presented here is actual minus expected. So the scale is not big, and I'm just going to talk you through this first slide and show you a couple more meaningful ones afterwards. So what we here is what's going on, because stroke improvement was in progress throughout the whole of the country at the moment. So there was a general trend of improvement, and the rest of England, this is what's happening here with mortality. We've got London as the already dotted line, and we've got Manchester here. Now Manchester went go live a little bit before we did in 2010. We've got London subsequently. We were go live sort of July 2010. It's probably better if I show you the 30-day mortality. I think this really is powerful. Early mortality, one could say that unsurvivable stroke is unsurvivable whatever you do, outside of hemicraniectomy or miraculous sort of clot retrieval, which wasn't really commonplace in 2010. But the real hallmark of good stroke unit care is reducing 30-day mortality. So there was definitely a trend of improvement nationally, but this was plateauing off by 2010. Look also what was happening. This is Manchester. This is Manchester. Sorry, this is Greater Manchester, the green line. It was improving, but then plateaued off, and it was plateauing actually before they went live. And after they went go live, there was really no difference. In fact, it was converging to the national average. Whereas what you had in London was it was improving before, and the reason for that is that the fact that I've moved on to 90-day mortality, but just the graphs look very similar, was that this is the designation process. So all the hospitals were focusing their intentions on stroke because most people wanted to be an acute stroke centre. So it was something of a Hawthorne effect, just being in the process, people were upping their game. But what you see after the go live here is a continued improvement, whereas Manchester was bottoming off, there's a continued improvement afterwards, and then quite a considerable gap in terms of mortality. Actual minus expected, this is Casemix adjusted, I should say. And this is the same for length of stay. Still a big difference. This is the total length of stay, HASU and SU combined in London compared to Manchester. So a significant difference. Manchester wasn't so good as national average, but came down to national average. London was better, but got even better after the go live. And if you want to sort of go back to what I've already sort of mentioned to you, why was this happening? This is a separate paper from the same group published in Stroke. If you look at the things in terms of process of care that might make a difference in terms of the aggregation of marginal gains, brain unit scans, gains of stroke units, having antiplatelet treatment, physio nutrition, swallow. This is what was happening in London before, and this is happening in London after. The comparator is Manchester over here. So probably the best way of looking at it is this is the situation in London before compared to the HASUs afterwards. So quite a big step change in these sort of things. Brain scanning within 3 hours, gone from 30% up to sort of 75%. This is in fact quite early on. And then you compare the London HASUs to the Manchester situation after reconfiguration. You can see that in every one of these metrics, London comes out better. So it's a bit like the Ronseal test. Ronseal is a product, a DIY product in the UK, and it has a slogan. It does what it says it does on the label. And essentially, if you think that stroke unit care works, if you take all the components of stroke unit and make them as good as they can be, then you should get a better effect. And if you remember the outcomes from the original stroke unit trials in the 1990s were that they reduced mortality, they reduced disability, and they reduced length of stay. So this is just an augmentation of that. So compared to the Manchester triage of just taking the patients for sort of thrombolysis treatment to sort of specialist centre compared to taking all-inclusive patients, what we saw with the London is that the London model reduced mortality, it reduced length of stay. There's increased evidence-based intervention chance, and the other important thing, which I hinted at to start with, is a greater pathway compliance with the ambulance services. So the ambulance service in London, they were overjoyed because prior to the London HASU thing, there were sort of piecemeal things like I mentioned St George's. Come 5:05, they were unsure of whether to take a patient in South West London to the local hospital or best redirect them to St George's, and there was all these sort of anecdotes of and conundrums, whereas this model of care is anyone with a suspected stroke just goes to one place. Okay, so I'm getting close to wrapping up now. So in terms of the bottom dollar, is all of this affordable? Remember, there's a £20 million investment in this above beyond the additional tariff or the existing what you would call WEAS. And this was, again, this is published work, and I'll just give you the highlights of it. Like any health economic paper, there's a huge amount of modelling and assumption in this, but and various adjustments. But the bottom line is that in the first 30 days, it costs. So for the whole of London, it costs an extra, getting on for about £4 million in real terms. But then you go out to 90 days, 3 months afterwards, it's actually saving, and it's saving as much as it's costing. And if you extrapolate out there, there's potential savings here. So reducing mortality, but also reducing more disability. So I think there is this sense that it is an upfront cost, but benefits come later, and obviously the benefits may be paid for in terms of healthcare, but may well be met not just in terms of healthcare costs, but social care costs as well as societal costs in terms of informal carers and so forth. So what do patients think about all this? Particularly people like their local hospital, or like going to the local hospital, have affinity with the local hospital. They probably don't really want to not go to the local hospital if they're ill. And this is work that we published from St George's at South West London. So we looked at just under 950 patients, again published in stroke, and it's a busy slide, but the bottom line is that patients don't mind. In this scenario, all they want to know is they're uncertain, they're frightened, they want to know they're going to get the best possible care, and this is what the model seemingly was delivering. So even with the repatriation, very few people minded. So in summary, there has been unprecedented interest in stroke services within the NHS over this period of time, and the HASU concept, no doubt, has been a product of this. There's a large investment in London with a new and radical model of care. It remains the biggest ever redesign of stroke services in the world. But we do have evidence of better outcomes and long-term financial savings. And although it's a very particular model of care for London, 32 hospitals all very close together, lots of people, there are, I think, transferable lessons for other, certainly metropolitan centres. And indeed, there's now redesign work going on throughout the UK looking at this. So the first time I got to speak about this subject was somewhere in 2012, and I ended because there's a vague Olympic sort of message, and we are an Olympic year. And I used to finish on this slide, which was a huge success for London in 2012. And we sort of, and I like to think that the London Stroke Strategy is an Olympic legacy. And here we are, 2016. I think not much has changed down here, I'm afraid, but we continue to be strong with the extra investment. Thank you very much for your attention.
Thank you so much, Geoff. That was fantastic. As I said, we don't have much time for questions, and if anyone has any further questions that they would like to add while we're talking, please do put them into your chat box. And Geoffrey, one of the things that you described was the difference in population between London having between 8 and 9 million people in an aggregated metropolitan environment versus Victoria having 6 million people but spread out across a wide level of diversity. Do you have any thoughts or comments about the value of getting somebody to within a 60-minute drive time, say, of a thrombolysis centre, but quite a low volume site where there's not really a stroke unit?
Listen, the geography is totally different, and the most important thing is from the symptom onset to the treatment time. So London, it was all about, because the travel time wasn't extended that much. We're talking about 18 minutes median travel time, so typical travel time, less than 20 minutes from wherever you are to get into a HASU site. We don't have the same sort of issues as geography, and the telemedicine situation for delivering thrombolysis has been well described and very successful in Victoria. I think there is an issue, though, looking at performance, and I wouldn't be blasé about that, because I think you need to think about, and this is why measuring it and putting the data out there is really important. In terms of what you need to be looking at is the association between the time of onset and the time of needle time, and looking whether or not there are differentials that can be gained. I mean, you need to think outside of your institutional bias if you're going to be involved in a project like this, and that is a huge credit of a lot of the stroke people. I mean, I mentioned Tony right at the beginning, so he ran the HASU, he ran his acute stroke unit at St Thomas's Hospital, which everyone knows that's by Big Ben, right opposite the Houses of Parliament, the House of the Lords, and that had been a top 5, top 10 stroke service, for the last 10 or 15 years, was not designated a HASU based on geography. So, and there was a huge bitter pill for him to take, that his unit wasn't going to be one of the vanguard of things. But I think we'll have to look at the greater good of things. So, in terms of the benefit now, I think you need to look at this in terms of when the symptoms start and how quickly can they get to somewhere. But it's important that when they get somewhere that they are treated efficiently, because the travel time may be modifiable. I mean, the current thing in the UK, which we're just discovering, is helicopter medicine transfers for stroke for endovascular retrieval. So before I left the UK, St George's was the first centre to have 24/7 thrombectomy, and we were taking a radius of people up to about 100 miles. You could get, from Ashford in Kent to Tooting in 20 minutes with a helicopter. Extraordinary, but that was really changing the whole face of what was possible in terms of conveyance. And the conveyance is one thing, but it's making sure that when the patients get there, that they're rapidly treated. And we had a standard within our metrics of a median door-to-needle time in at least half cases of 30 minutes. And at 75% within 45 minutes, and that's what we were looking for. Acknowledging that you can't put everybody, you can't treat everybody within 30 minutes. So yes, is there?
Well, thank you, Geoff. Just given the time and the fact that this is an evening session, we will finish there. Thank you so much, everyone, for attending. We'll be signing off now, but we do ask that you please stay on and complete the exit survey. We'd really love to have your feedback. And thank you again, Geoff, for this evening's presentation.
Thank you. Thank you for your attention.